I will be discussing the answer key for selected items in the second long exam for disease prevention and control. Let's begin with number 46. An unvaccinated 10-year-old boy was admitted to the isolation ward of the provincial hospital after he presented with moderate grade fever, odynophagia, voice hoarseness, and foul-smelling nasal discharge. There was note of multiple cervical lymphadenopathies, resulting in bull neck appearance. An examination of the buccal cavity revealed presence of a pseudomembrane in the tonsillar area. He was eventually diagnosed with diphtheria. After 1 week of hospitalization, the boy was discharged improved, but the patient might still potentially shed the etiologic agent, which is your Corynebacterium diphtheriae. Now, this represents which type of carrier. Choosing the best possible answer, the key words here are the patient might still potentially shed the etiologic agent despite being improved in terms of clinical symptomatology. This is the definition of a convalescent carrier, wherein their patient is still highly infectious, despite the fact that the natural history of the disease is already towards the recovery part or already beginning to experience resolution of symptoms. Number 47. After examining patients, all house staff personnel routinely wash their hands before seeing the next patient. This simple, practical, effective public health intervention, which is hand washing, breaks which specific link in the chain of infection. If you read your manuals or your review notes in manual in disease prevention and control, or if you refer to my slide deck, you will notice that hand washing is something that can be implemented across various links of the chain of infection. However, the scenario says that the health staff personnel would wash their hands before seeing the next patient, hinting that this possible etiologic agent has not yet successfully entered the susceptible host, indicating that what you are trying to break here is the portal of entry, choosing from the best possible answer among the options. Number 48. After having unprotected sex, a freshman medical student complains of painful urination with associated foul-smelling purulent penile discharge and itchiness in the urethral meatus. He most probably has gonococcal urethritis, a sexually transmitted infection having which type of reservoir? In the lecture that I gave you previously, in the natural history of infections, or if you look at the life cycle, there are what we call your reservoir, which are basically um, the natural source of the pathogen. This is where they would normally thrive and replicate. Now, there are different types of reservoirs. You have your human, animal, and your environmental reservoir. However, there are certain infectious processes and communicable diseases which do not have reservoirs. Rather, it's a type of infection that would directly be introduced from one susceptible host to the next. This is basically the reason why, when we talk of sexually transmitted infection, it is through the sexual intercourse that the etiologic agent is passed on to the next susceptible person. Therefore, there is no reservoir involved in transmission of most sexually transmitted infections, including your gonorrhea or your gonococcal urethritis. Number 49. Which of the following diseases has direct transmission? Basically, when we talk of your malaria, your schistosomiasis, or your typhoid fever, all of these have indirect transmission. When we talk of your direct transmission, often this would involve direct physical contact, or sometimes these are what we call infectious agents that could be transmitted by droplet spread. Let me remind you that there is a difference between a droplet spread and your droplet nuclei. When we talk of your droplet spread, as exemplified by your meningococcemia and your pertussis, these are directly transmitted. Why? When we talk of your droplet spread, the etiologic agents are often present in the droplets that are big molecules that when you, let's say, for example, cough or when you sneeze, because the agent thrives in the bigger droplet molecules, that would also require short distances of travel. And so you need to be physically close to someone, let's say, with a infectious agent for you to get the risk of being susceptible to that infection. In contrast, when we talk of your droplet nuclei are basically smaller relative to your droplets. And because the droplet nuclei are smaller in size, they remain suspended in the air. And so, for example, your droplet nuclei could be exemplified by your tuberculosis or your measles. For example, if I have pulmonary tuberculosis and I cough out and I do not cover my mouth, I do not practice proper cough etiquette. After I cough, I leave the room, but the droplet nuclei remain suspended in the air. So even if the next susceptible host enters the room, even if there is no direct contact with the sick person with tuberculosis, you can still acquire your Mycobacterium tuberculosis. So that is why we need to differentiate your direct transmission involving your droplet spread, and this is exemplified by your meningococcemia, versus your indirect transmission, as exemplified by your airborne droplet nuclei, as exemplified by your measles and your tuberculosis. Which of the following characterizes your food intoxication or food poisoning? So, food intoxication and food poisoning are synonyms, and you must differentiate this from your food infection. Now, when we talk of your food intoxication, as the name implies, you already ingest or you consume preformed toxins from existing pathogens. In contrast, when we talk of food infection, you acquire the etiologic agent, let's say a virus or a bacterium or a fungus or a parasitic microbe. The presence of these pathogens inside the body would then precipitate a reaction, let's say for you to produce antibodies of the because of the presence of the antigen. So we need to differentiate your food intoxication versus your food infection. So with food intoxication, normally the incubation is generally shorter, about 2 hours perhaps, and this would resolve at a faster rate in contrast to your food infection. Most food intoxications would resolve within 24 hours, and because you just ingested the preformed toxins, you do not expect systemic clinical manifestations such as your fever, nausea, vomiting, abdominal colic, or diarrhea, which are more commonly encountered in your food infection rather than your food intoxication. Number 51. This is a very favorite question in the physician licensure exam. In the prevention and control of foodborne infections, at what temperature range will most bacterial species grow quickly? Or basically, they're asking, what is the range of the danger zone? And this is about from 5 degrees to 60 degrees centigrade. Temperature of greater than 100 would be this is what we refer to as your food a hot food zone. In the hot food zone, basically your bacterial species or your etiologic agents become destroyed. Your temperature of 0 to 5 would represent your cold food zone, while those less than -10 degrees would represent your frozen zone, frozen cold zone. Now, in this temperature range, you do not expect your pathogens to multiply and grow. And so the danger zone is the area or the range where pathogens would most commonly thrive and even have the capacity to replicate and multiply within that temperature range. Next, trachoma is a priority neglected tropical disease, recognized as the leading infectious cause of blindness worldwide, and is targeted by the World Health Organization for global elimination as a public health problem come 2030. This is endemic in many developing countries in sub-Saharan Africa, as well as in developing nations in Asia, where there is inadequate water supply and sanitation. I think this is the clue rather to the answer key. So when we talk of water washed diseases, this would also include your scabies or your pediculosis or your kuto. No? Often this is commonly encountered in areas where there is lack of water supply. To differentiate this from your waterborne infections, when you say waterborne infections, you drink water that would contain pathogens. When we say water-based um, infections, these are exemplified by your schistosomiasis, where the body of water plays a pivotal role in the life cycle of the vector or the reservoir, while your water-related infections are often secondary to your vectors. So when we talk of your mosquitoes or uh, other types of water-related infections, this is where you would encounter uh, such such conditions. Okay, so where was I? What was I saying? Okay, so it's water wash. Next, number 53. Some arthropods of medical importance cause direct injury to humans. Scabies, a water wash infection, is known to cause your ectoparasitism. So when we talk of scabies or your crabs, or we talk of pediculosis or your lice, they don't normally enter the human body, but rather they would thrive in hairy areas of the body. So that's why it's ecto, meaning representing something that is outside of the human body. And of course, this is a parasitic infection. Ergo, this is what we refer to as your ectoparasitism. Now, in the Philippines, when we talk of your lymphatic filariasis, which is a priority neglected tropical disease, there are three genera of mosquitoes that are commonly encountered to transmit your lymphatic filariasis. And the three more common genera of mosquitoes known to be vectors of your LF or your lymphatic filariasis would be your Aedes, followed by your Culex, and then your Anopheles. Now, truth be told, your Mansonia can actually also transmit um, your lymphatic filariasis, but this genus of mosquito is not so commonly encountered in the Philippines. So if I were to choose the best possible answer, I would most probably also answer Mansonia, because in the Philippines, the leading genera of mosquito vectors for your LF would be your Aedes, Culex, and then your Anopheline mosquitoes. Um, in the prevention and control of dengue, the Philippine Department of Health advocates the 5S strategies, which includes the following key actions, except. So the 5S strategies is a rehash or an improvement of the previous 4S strategy. Options B, C, and D represent the three S's of the 4S strategy, followed by search and destroy for the mosquito vector breeding places. And the fifth S would be to sustain hydration. Be mindful that when we talk of dengue, because this is a viral infection. Most viral infections are generally self-limiting, meaning to say they will spontaneously come and they will spontaneously go, even in the absence of antimicrobials such as your antibiotics. So we reserve the giving of your antibiotics for your bacterial, but we do not give it for your viral infections. Ergo, systemic use of antimicrobial agents is not usually part of the recommendations under the 5S strategy. Moving forward, we now go to number 56. In the Philippines, malaria is primarily due to which species? I think this is just more of a recall, and the answer here will be your Plasmodium falciparum. Perhaps I just want you to be reminded that your Plasmodium falciparum is also known to produce what you call your malaria encephalitis. So it can also cause significant neurologic deficits in or cerebral malaria in worst cases of your malaria. Number 57, schistosomiasis is regarded as an occupational hazard. In fact, it is considered a biological hazard among farmers who frequent wet rice paddies. And the primary vector for this priority neglected tropical disease is your Oncomelania quadracea, which is a molluscan species. It is a snail. Number 58, in the control of vermin-borne infections, which is often used in gassing of rodents. So sodium hypochlorite is your bleach. Hydrochloric acid is basically vinegar. Barium carbonate is usually a rodenticide that we give as food for if you want to kill rodents, such as your sewer rats or your mice. When we talk of gassing, the best possible gassing of vermin, such as your rodents, it would be your calcium cyanide. Number 59. Zara died from hepatorenal and hemorrhagic complications of whale syndrome, a severe and toxic form of leptospirosis. Zara's untimely demise could have been prevented if she received proper post-exposure prophylaxis after wading in flood water, given the fact that she had an infected ingrown toe wound from a recent pedicure injury. So if you are familiar with the risk stratification of leptospirosis, this was presented in the lecture slide deck that I gave you. Normally, if it's just a single exposure in flood water and there are no soft tissue infections or open wounds for the body parts that have been immersed in flood water, then we call it low risk. But once there is an open wound, and that could be a potential portal of entry for your Leptospira interrogans or these spirochetes, so it now becomes moderate risk. High risk would entail prolonged exposure to flood water. For example, if you happen to reside in flood-borne or flood-prone communities, for example, if you are from the Kamanava area, sometimes they would have perennial floods, even though there are no rain, or even in the absence of your precipitation, and there is a prolonged duration of floods, and that is your high risk. This is actually a joker number letter D because there's no such thing as extreme risk leptospirosis risk classification. And the last that was the last number for me is this. Human immunodeficiency virus pre-exposure prophylaxis is highly recommended for. So when we talk of your pre-exposure prophylaxis, as the name implies, it refers to individual. It's a primary prevention for individuals who still do not have the disease, but for one reason or another, they are at a higher risk of acquiring their human immunodeficiency virus. If you read number 20, if you go with option 22, option letter B and option letter C, This is where your post exposure prophylaxis will come into play. Um, we reserve your post exposure prophylaxis for victims of sexual assault or for healthcare professionals who sustain needle prick injuries. And so B and C would refer to post exposure prophylaxis. Option D, because the patient is already HIV reactive. So even if the patient is already virally suppressed, the mere fact that he already harbors the virus in the retrovirus in his system, there is no more role for pre-exposure or post-exposure prophylaxis. Rather, from a public health perspective, the goal is to have 95, 95, 95 U equals U, wherein we say that 95% of individuals who are sexually active should know their HIV status. If you are HIV reactive, then we want 95% of that population to be started on antiretroviral therapy, which you can get for free in most social hygiene clinics throughout the Philippine archipelago. And of those who are already taking your antiretroviral therapy, we want 95% of these PLHIVs to have viral suppression. Because if you have viral suppression, you're unable to detect the virus, undetectable retrovirus, then it is untransmissible. So even if you have the HIV, as long as you religiously take your antiretroviral therapy, then the risk of transmission would be very low. So those are the questions assigned to me. So I hope I was able to clarify the answer key. If there will be any questions, please feel free to reach out to the faculty of the Department of Preventive and Community Medicine. So with that, thank you for listening.